Bismillah ar-Rahman ar-Rahim. Good day, everyone. I'm Dr. Mahmoud Sheikh, nephrology learner. Today, I will be presenting a simple MCQ case. The goal is to help to broaden your differential diagnosis approach and how to think through solving an MCQ question. My view is that this way of thinking during your theoretical study will reflect positively on your exam performance. I hope you find it useful. Today's case is about GN, and let's keep our minds open to all kidney-related disease as we work towards the final diagnosis. Our case today is 25-year-old female present with ankle swelling that have been getting worse over the previous few weeks. She thought this was due to dancing-related injury and had been taking a variety of analgesics. On examination, she was thin, blood pressure was normal, there was bilateral ankle edema, there was a soft ejection systolic murmur at the left sternal edge. GVP was not elevated, chest examination was normal, urine analysis denotes blood 4+ and protein 3+, creatinine 212, which is elevated, serum albumin 28, urine PCR is 462, which may be around 4 grams and 600. Serum complement C3 is 75, which is normal, not consumed. Serum complement C4 is 42, and CRP is 5, normal. ANCA test is negative. The question is, what's the most likely cause of her impaired renal functions? Is it form of post-infectious GN like post-streptococcal or staph-related, or is primary or secondary IgA nephropathy, or is it infective endocarditis, or simply interstitial nephritis, acute or chronic, or maybe complicated papillary necrosis from her medications? Okay, let's start with the age. When we are thinking about the age categories, the first thing to consider is that a 25-year-old is typically considered a young adult. We usually define young adulthood as ranging from 18 to 35 years old, and the middle age from 40 to 65. And we consider older adulthood or senior age, as we call, as 75 years and above. Here we have 25-year-old patient, which places her in the young adult category. Okay, in nephrology, common disease at this age include things like primary GN, primary IgA nephropathy, which often has onset between 15 and 35, which is typical onset. We can also see post-infectious GN, which is more common in children, but can occur in young adults as well. Additionally, while minimal chain disease is more common in children, it can be present later, and we could call it late onset minimal chain disease, which actually in real life could differ from childhood in forms of presentation or even the response to therapy. Lupus nephritis, for example, typically at age from 20 to 40, amyloidosis and other dysproteinemias typically in older adults above 60, vasculitis in older adults above 60 also. Membranous nephropathy can appear in young adults, though it's more common after the age of 30 or 40, typically to 60 years of age. Finally, some disease like NGBM has what's called bimodal peaks, one from 20 to 30 and the other from 60. So these are some of the key conditions we consider in a 25-year-old patient. Here is also mentioned that the patient is a female. When considering common nephrology-related disease in female patients, we see that lupus nephritis is one of common, with a female to male ratio of about 9:1. While secondary membranous nephropathy is also more common in females, maybe due to lupus or something, primary forms tend to be more common in males. Additionally, AKI risk factors in general, including being a female, as mentioned in KDIGO 2012 guidelines, as well as CKD prognosis and CKD vulnerability will be more common in females. Actually, even angioedema from usage of ACE inhibitors will be more common in female patients more than male. Thiazide-induced hyponatremia would be more common in female patients and will affect the risk and the prognosis. Even the infertility, while we are talking about GN case now, infertility from cyclophosphamide more common in females. Furthermore, females with Alport syndrome, the X-linked, while they are often considered as carriers, they are at manageable risk of kidney disease progression. Also, heterozygous female carriers of Fabry disease are at significant risk of renal progression and shouldn't be considered simply asymptomatic or unaffected patients. There are also in general high risk of poorer outcomes in AKI or renal replacement therapies for females, especially over 50 years. Conditions like Tino syndrome and fibromuscular dysplasia, even UTIs are more common in females more than males. Certain complications after transplant, like allograft pyelonephritis, are more relevant also in female patients. Okay, in our case, because her symptoms developed over a few weeks, we consider this as an insidious or subacute onset, which is common in conditions like IgE nephropathy, lupus nephritis, and membranous nephropathy, and MPGN, which would be more in weeks to months. In contrast, conditions like post-infectious GN or anti-GBM disease usually have more abrupt onset. Vasculitis could be acute or subacute according to severity of the case. Crescentic form of any of the previous, usually with acute onset and rapid course and deterioration. They mentioned in the head of question that the patient received analgesics after ankle trauma. So when considering the impact of analgesics, especially non-steroidals, on kidney health, it's important to remember that they can contribute to analgesic nephropathy, for example. Also, in general, they cause sodium and water retention, potentially lead to resistant hypertension. They can also be linked to conditions like minimal change disease and membranous nephropathy, occasionally FSGS. Non-steroidal also can cause reversible AKI by afferent vasoconstriction, which, as mentioned, temporary. Also, it's associated with acute interstitial nephritis, also cause hyperkalemia, the increased risk of bleeding, which is impact on the overall bleeding cascade, which is important to consider before procedures like renal biopsy to omit the non-steroidal the patient is taking in case the patient has a normal renal profile. Over the long term, they can also contribute to renal cell carcinoma and certain metabolic acid disturbances like distal RTE and high anion gap metabolic acids. They mentioned here also the patient is thin. When we consider BMI in nephrology, thinking if the patient is thin or obese. Thin patients in nephrology may be more vulnerable to certain conditions, I mean the lower BMI patients, like thiazide-induced hyponatremia or exercise-induced hyponatremia. They might also be at higher risk of primary FSGS recurrence after renal transplantation and more susceptible for protein energy wasting in CKD status. What if the patient was obese in the head of question? They would be at high risk for obesity-related glomerulopathy, which is known as an ORG, or to secondary adaptive form of FSGS, the pre-Hilar pattern. Also, maybe the higher risk for OSA and secondary hypertension. Also, the albuminuria incidence and progression. After transplant, they will be more vulnerable to delayed graft function and new onset diabetes after transplantation. Female obese patients in particular may also face increased risk during pregnancy, like preeclampsia and renal worse outcomes, especially if the patient has underlying conditions like lupus and Sjogren's syndrome. Also, obese patients may be at high risk to develop calcific uremic arterioles, CUA. Also, they are at high risk for any post-surgical complications. They mentioned here that the patient has ejection systolic murmur. Okay, in nephrology, murmurs can arise from several causes, like infection-related murmur in infective endocarditis, especially in patients with hemodialysis, central lines, or immunosuppression, often affecting the tricuspid and the mitral valves. And the patient will present with toxemia, embolic signs, or new onset murmur, or even changing the character of the old murmur. Another cause can be the pericardial friction rub in uremic pericarditis, which, while not a true murmur, can sometimes be mistaken for one. This murmur may be scratchy, triphasic, and best heard in uremic patients while leaning forward. Also, we have valvular calcification in patients with long-standing CKD can lead to stenosis or regurg, producing murmurs as well. Systolic ejection murmur in aortic stenosis, which got heard at right upper sternal border, or mitral regurg or stenosis murmurs with mitral annular calcifications. Additionally, volume overload can cause chamber dilatation and functional mitral tricuspid regurg murmurs, holosystolic murmur at apex in case of mitral affection, or at lower sternal border in case of tricuspid affection. Also, we have high output states like anemia, pregnancy, hyperthyroidism can also result in soft systolic murmur at the left sternal border. All of these are functional and not necessarily indicative of primary valve disease. In the scenario described, vital signs play a crucial role. For instance, blood pressure measuring, important, especially if they have mentioned changing from position, from lying to upright or standing, which can indicate orthostatic hypotension, often seen in volume-depleted patients. On the other hand, if the patient is hypertensive, it might indicate secondary hypertension seen in conditions like vasculitis or lupus nephritis or any other form of GN. These clues from vital signs can guide diagnosis and management, helping determine whether the patient might need diuretics, albumin, or safe antihypertensive medications. Respiratory rate and presence of fever can also offer valuable insights, indicating possible respiratory compromise or any infection. Okay, here it's also mentioned that the GVP is not elevated. An elevated jugular venous pressure can be caused by conditions like heart failure, fluid overload, pulmonary hypertension, tricuspid regurg, or stenosis, maybe some case of infective endocarditis, maybe in constrictive pericarditis. We will see what's called cosmal sign, increased GVP while in inspiration, maybe also in cardiac tamponade, and if it's fixed, will be in superior vena cava obstruction. On the other hand, decreased or collapsed GVP can be seen, as mentioned, hydration, hypovolemia, bleeding, severe hypoalbuminemia, maybe in third spacing, or even in shock with severe sepsis, sometimes even in early cardiac tamponade. Here it's mentioned for urine that you have proteinuria and hematuria. If the patient has both significant proteinuria and hematuria along with elevated creatinine, mostly suggests mixed nephrotic and nephritic syndrome. This means there is combination of heavy protein loss and blood in urine, often seen in conditions like certain types of GN, maybe IgA nephropathy, MPGN, or lupus nephritis or vasculitis. While other like minimal change and membranous nephropathy, FSGS, amyloidosis, will present with pure nephrotic pictures. Here mentions that the patient has both C3 and C4 normal. It suggests that the complement system is not being consumed. Typically, complement levels are low in conditions like lupus, where both C3 and C4 are consumed. C3 alone can be consumed in infection-related GN or certain complement-mediated TMAs. C4 might be low in cases like cryoglobulinemia. On the other hand, complement levels usually remain normal in conditions such as minimally changed disease, membranous nephropathy, FSGS, or ANCA-associated vasculitis or anti-GBM disease. At the end of the equation, talking about CRP and ANCA test, in general, when CRP test is negative, generally help rule out the infectious cause of GN, and when ANCA test is negative, it helps exclude the presence of ANCA-associated vasculitis. So having both of these tests come back negative helps to narrow down the possible diagnosis significantly. Back to our options and our distractors. In summary, when considering the differential diagnosis conditions like post-infectious GN usually present with low complement levels, typically C3, and presence of systemic signs of infection, and often history of recent infection, typically from 1 week to 3 weeks, which will differentiate this from IgA nephropathy maybe after 3 days to 1 week. But in post-streptococcal infection, sore throat or skin infection will be after 3 weeks. Similarly, conditions like infective endocarditis also show complement consumption, also C3, maybe C4 be normal or consumed. Systemic symptoms could be present, maybe absent in subacute cases. Interstitial nephritis may cause some proteinuria and hematuria, but not usually as the nephrotic range, usually in range of 1 gram, subnephrotic range, what's called tubular proteinuria. Papillary necrosis typically associated with chronic analgesic use and doesn't usually lead to heavy proteinuria or murmurs. IgA nephropathy stands out because it can present with both nephrotic range proteinuria in 5% of cases and hematuria in its nature without the consumption of complement levels. So the final answer here would be the IgA nephropathy. Thank you all for listening. I hope it was useful for all of you. Thank you so much. Goodbye.